All right, thanks for having me. Can everybody hear me okay? Okay, good. And yeah, I'm from West Virginia originally, my wife and I both, and it's good to be back after about 4 years away. So tonight I'm going to talk about concussions, and this is the most popular topic in sports medicine these days. It's also one of the most poorly understood topics as well. So we'll cover a lot of information. If you guys have any questions at all, just raise your hand, and this is meant to be more of a discussion, but I'll present a decent amount of material, and we'll go through this. Again, if you have questions, just stop me and let me know. So what I'm going to cover tonight is divided into two different parts. The first part of the talk revolves around 3 questions. So I'm going to start by talking about what a concussion is. I'll give you a basic definition and go through that. Secondly, we'll go over how a concussion is diagnosed, and then how it's treated. The second part of the talk is going to revolve around questions that everybody has. If they have a child who plays sports, if they're a former athlete, if they're a coach, etc. So these questions include: is it safe for my child to play sports? How can my child prevent getting a concussion? And what are the long-term risks, if any, of concussion? So before I start, concussion again is a popular topic. It's a hot topic in sports medicine these days, and there are a few reasons for that. So recently, with the NFL, there's the concussion lawsuits that's come about in the last few years, and there's this question whether these athletes who've been playing in the NFL for so long are having problems with their brains later in life. Additionally, there are a lot of equipment that's come about in the last few years as far as preventing concussion. So you can see this young lady right here with the headgear. She's a soccer player. There are various helmets or even things that are attached to helmets that are thought to be helpful. One thing that's come out recently are these little monitors that go behind an athlete's ear that can be worn during a game. And a parent or a coach can use these little monitors on the sideline and see how much impact they're having. So there's a lot out there, and if that's not enough, there's actually a movie coming out with Will Smith called Concussion. This comes out, this says Christmas. This is based on a neuropathologist who was the one that kind of brought forward some of these questions as far as NFL athletes having problems later in life after sustaining numerous concussions during their playing career. So, popular topic. So going back to the definition of what a concussion is, this is put forth by the American Medical Society for Sports Medicine, and I'll break this down further, but essentially what it is a traumatically induced transient disturbance in brain function that's caused by a complex pathophysiologic process. And I'm going to break each of those down for you. So traumatically induced, I break trauma down into 2 separate entities. So one is direct trauma, and that can be player to player. So an athlete sustains a head injury because he or she had an impact with another player. They can also have trauma that's athlete to object. So the most common thing is actually the ground or the playing surface. These can also be things like the ball in soccer or basketball, or even like a goalpost in soccer or football. Indirect trauma involves more of a whiplash injury, and that's a rotational force that the brain is subjected to. As you can see in this picture, this football player is tackling the other football player. The football player that's being tackled doesn't have direct trauma to his head, but there's this whiplash mechanism that can create injury to the brain as well. So that's trauma. There are 2 different types primarily. Transient. So a concussion is transient in that it resolves without intervention, and the main intervention for concussions are rest, and we'll talk about that here in a few slides when we talk about how a concussion is managed. There's a disturbance in brain function, and what that means is that the brain's just not functioning as it normally does, and that can be manifest in a handful of ways with various signs and symptoms that I'll go over here in a few slides. The complex pathophysiologic process that's associated with a concussion is somewhat poorly understood. We do know a few things. So there are alterations in blood flow to the brain, oxygen use, and glucose use. And it's thought that these alterations are the things that actually cause the disturbance in brain function. So that's kind of what a concussion is. As far as diagnosing a concussion, we use 3 different components: history, physical exam, and then objective testing. And I'll go over each of those individually. So the history includes the mechanism of injury. So there has to be a trauma to the head, whether that's an indirect or direct trauma. There are things that can masquerade as concussion. So for example, dehydration. Some athletes may get down when they lose a game. They may get down when they make a bad play, fumble the ball, etc. And those types of things, those symptoms can overlap with a concussion. So there has to be a mechanism of injury. Symptoms, and I kind of outline that down here in this figure. There are various symptoms for concussion. Most of those are kind of vague symptoms and general symptoms. The most common two are headache and dizziness, but you can have anything from confusion, difficulty concentrating, difficulty sleeping, problems with light sensitivity, noise sensitivity, and there's a whole list. So there are various symptoms that are associated with a concussion. And then the last thing on there is signs. So I put signs on there, and these are things that the healthcare provider will observe with the athlete. So some athletes have what we refer to as a glazed appearance. So they just may not look like they're really focused or into the game. They may be stumbling around. They may not be able to answer appropriate questions. And so we call those things signs. So history, mechanism of injury, symptoms, and signs. The other part of diagnosing a concussion is the physical exam. Observation is the first part, and that goes along with the signs of a concussion. So how does the athlete look? The next part of the physical exam is the neurologic exam, and I'm not going to go into detail with it, but that's something that the healthcare provider would do with the athlete to check various things. And then lastly, with physical exam, there's something that I call provocative maneuvers. And these are an extension of the neurologic exam. And what these do is they attempt to elicit symptoms that the athlete that may not show up on the neurologic exam. So examples of that is having the athlete move their eyes very quickly to try to focus on a moving finger, having them try to focus on a finger that's coming closer to them. There are various balance tests that can be used, and sometimes even just having the athlete jog will provoke their symptoms when other things that you're doing don't provoke those symptoms. So those are the 3 main parts of the physical exam. So when we suspect that an athlete has a concussion, we'll kind of go through all 3 of those. Now, objective testing, it's kind of a mixed bag. There are a lot of various objective tests. And as you'll see in the next slide, none of them are better than another. So maybe you've heard of some of these, maybe you haven't. So just kind of going down the list, the SAC, the SCAT, NFL Sideline Concussion Tool. The SCAT and NFL Sideline Concussion Tool are very similar. The SAC is actually part of the SCAT. The SCAT also includes BESS, which is a balance test. So I don't want to get too far in detail with these, but essentially what they're doing is they're testing things like orientation. So you're asking the athlete, where are you? What quarter of the game is it? What's the score? Who are we playing? Who were we playing last week? And then some of those also go into concentration. So having the athletes repeat numbers backwards, months backwards, remembering words, etc. And then there's also the balance testing. Where I did my fellowship at ECU, we used the BioSway device, and you can see it here on the right. We did that as a baseline test before. All the athletes had that before their season. And if they had a suspected concussion, they would get retested and see if there was any change from baseline. some of the other more popular tests are what we call neurocognitive tests. And those, again, test things like reaction time and memory. And a lot of athletes, for example, in Jefferson and Berkeley County, all the athletes in high-risk sports and also the athletes who actually just want to do the test have that before every season. And if they have a concussion, what we do is we retest and see if anything's changed from their baseline. So this is from the American Academy of Neurology in 2013, and they said that a combination of objective tests is likely to improve diagnostic accuracy. However, there's insufficient evidence to determine the best combination of tests. So moving on to concussion treatment. So initial treatment simply involves removing the athlete from play. This study from the Journal of Neurotrauma in 2015 looked at two different groups. So one group, both of them were diagnosed with a concussion. One group, however, within 24 hours had subsequent head impacts, and they found that group had more symptoms and a longer return to play. So from the standpoint of the athlete's safety, it's important to remove them from play as soon as a concussion is suspected. There's this phrase that we use, when in doubt, sit them out, and I think that's definitely true. Assessment should be made for red flags, and what those are things that may signify that an athlete is having more than a concussion. So if they're having some bleeding in their brain, if they have an injury to their spinal cord, they may also have a concussion, but there are some things that are a little bit more serious than a concussion that need to be dealt with right away. And so the healthcare provider will assess for these kind of red flags. Now, definitive treatment for a concussion is kind of at its base is simply physical and mental rest. So when we diagnose an athlete with a concussion, what we want them to do or not to do is rest. So if they need alterations with their schoolwork or their classroom work, so if they need to be out of things like computer class is particularly bothersome, math class, they shouldn't be texting a lot, shouldn't be watching a lot of TV, shouldn't be playing video games, shouldn't be playing on their smartphones or tablets. So we try our best to rest them as much as possible. One thing that I forget to mention a lot is these athletes shouldn't be driving. And I forget to mention that a lot to parents, and that's important to remember. There's a study from neuropsychology in 2010 that looked at two groups in the emergency department. So the first group were diagnosed with concussion or mild traumatic brain injury. The other group just had an orthopedic injury like a sprained ankle or an injured knee. And after the diagnosis was made, they immediately tested them in a driving simulation, and the group with the concussion did a lot worse than the group without a concussion. So these athletes shouldn't really be driving, at least for the first 24 to 48 hours, and maybe even longer than that. So after diagnosis, the question becomes, well, when can the athlete go back to playing sports? And this is kind of universal as far as youth sports, high school, NCAA, and even professional sports, with a few tweaks at each level. But in general, all of these should be considered, and all of these should be met before an athlete returns to play. So number one, the athlete should be symptom-free for 24 hours. They should be back to school full-time without any issues, so they shouldn't be getting headaches or anything in math class or at the end of the day. They should be sleeping normally, and they should be off any meds that were started for their concussion. So they shouldn't be taking Tylenol for a headache that started since the concussion. They should also have a normal neurologic exam, and then negative provocative maneuvers, which I talked about before, some of the tests that we do to try to bring those symptoms on. A lot of athletes will have the neurocognitive testing baseline before their season starts, and so that should really be normalized. There are some exceptions to that, but in general, you want that to be kind of back to baseline as well. And then there's this idea of a symptom-free waiting period, and I'll talk about that later on, but that's essentially, is there evidence that after the athlete's asymptomatic and back to their baseline, should they wait a few more days? Should they wait 3 days? Should they wait a week? Is there any basis or evidence for that? And we'll talk about that later on. So once an athlete's met all of that criteria, the next thing is getting them back to play. And this 5-step process is universal with youth sports, with high school, with NCAA, and also professional sports. So it's a 5-step process. So once all those criteria are met on the previous slide, what we do is we start them with light aerobic activity. If they pass that the next day, they can go on to sport-specific drills. If they pass that, they can go on to a non-contact practice. And then after that, they can go on to a contact practice. And then if they pass that step, then they can go on to a regular game. And so to pass each step, you can't have any symptoms that come back. If they do have symptoms or issues that develop, what we'll do is we'll rest them for 24 hours and then repeat at the level where they didn't have symptoms. So if they're in a non-contact practice and they start having a headache, rest them for 24 hours and you'll start them back doing sport-specific drills and then progress from there. And that's kind of universal at every level. So these are some factors that suggest a prolonged recovery with athletes. So athletes with a history of concussion tend to have, so if they're diagnosed with a concussion and they had a prior concussion in addition to that, they tend to have a prolonged recovery. The number, severity, and duration of symptoms also predicts a prolonged recovery. Females tend to have a slightly prolonged recovery compared to males. Younger athletes, their brains aren't as well matured, and so they have a longer recovery as well. If an athlete has a history of headaches, they tend to have a prolonged recovery as well if they have learning disabilities. And there are certain symptoms that predict prolonged recovery as well. This is dizziness, fatigue, and fogginess, early amnesia, and disorientation. So it's also important to remember that every athlete is unique and every concussion is unique. So when an athlete comes to me and they have a concussion, we evaluate that athlete and that concussion, irrespective of anything else or any other concussion they had in the past. So that's one of the key points of this lecture. Every athlete's unique, every concussion is unique. So just as a summary for what I just went over, this is the first part of the talk. So we talked about the definition of concussion and how it's a traumatically induced transient disturbance in brain function caused by a complex pathophysiologic process. So there has to be a head injury. It's going to usually get better on its own. There's a disturbance in the way the brain is functioning, and that's what causes those symptoms. And then there are various things that are going on with the brain that causes that. Diagnosis is through history, physical exam, and then also objective testing. And then we talked about management of concussion, so removing these athletes from play as soon as possible, resting them, and then we talked about the return to play progression as well. So moving on to some specific questions, and these are questions that everybody has. So is it safe for my child to play sports? The focus here is going to be on youth and high school sports, and it's going to be on football and soccer because that's what we're akin to seeing, and that's what our kids are playing mostly, and that's where the highest risk is. I'll talk a little bit about the NFL and professional sports as well, but most of it's going to be youth and high school. So looking at youth sports as far as risk, for males, football is the highest risk, followed closely by ice hockey, then lacrosse and wrestling. With females, soccer is the highest risk, followed closely by lacrosse and ice hockey, and then also field hockey and basketball poses somewhat of a risk. So this is a study from the Journal of Pediatrics in 2013. They looked at 8 through 12-year-old football players. Over 11,000 athletic exposures, so those are games or practices. There were 20 medically diagnosed concussions, and when you do the math, the rate of a concussion in a game is a little over 6 for 1,000 exposures, whereas in practice it's 0.24. So there you can see there's a huge difference between practice and a game. Athletes have a higher propensity to get a concussion during a game than they do in practice. This study from JAMA Pediatrics from this month looked at youth football concussion rates. They found that there are 1.5 per 1,000 game exposures. And when you look at one season concussion risk for any given athlete, it was about a little over 3%. And that's true from 2012 and 2003 as well. This study from JAMA Pediatrics last year looked at female youth soccer concussions. So it was from 2008 to 2012, and they followed 351 female soccer players aged 11 through 14. 59 concussions were diagnosed. So that's about 1.2 per 100 exposure hours, so practices and games. They found that heading the ball comprised 30.2% of concussions. And when I say heading the ball, that's the act of heading, so that's not just the ball hitting the head. That's the potential for another player to contact the athlete's head as well. So it's not just heading the ball, that's the act of heading. And probably the most surprising thing is that over half of these kids continued to play after they had symptoms. And so, I'm not going to talk much about kind of community awareness, but that's something that's very important, that these athletes should know the signs and symptoms of a concussion and properly report them. So looking further at some epidemiology studies. So this came from American Journal of Sports Medicine in 2012, and they looked at all sports for youth sports, just for high school. And so one of the most interesting ones was highlighted on one of those previous studies. So competition versus practice, about 6 times higher concussion rate with competition versus practice. Again, football is going to be your highest number, and then girls soccer. As far as the rate itself, football was just a little bit higher than boys ice hockey. So there are a lot more football players. The teams are just bigger. It's a popular sport, especially in this area, but just even around the country. Ice hockey is risky. It's not as popular a sport, so overall there are going to be less concussions, but the rate is fairly high. And then this study continued. So girls had a little bit higher rate than boys did. The highest mechanism was player-to-player contact, and the second highest was player-to-surface contact. So moving on to high school football specifically. So this was JAMA Pediatrics from this month. And then the important thing, with this is that the one season concussion risk for these high school football players, and this was from 2012, was almost 10%. Concussion in high school soccer, JAMA Pediatrics last month. So they looked at a lot of athletes. I'll just kind of do the highlights here. So males had a little bit less of an lower rate than females did, so 2.78 versus 4.5, and those are per 10,000 exposures. Again, contact with another player was one of the risk factors, or one of the highest risk factors, and then the act of heading. So males, again, about 30%, females about 25%. And so that raises the question that's been raised for the past few years: should we outlaw heading with soccer? We do know athletes underreport symptoms. This is a study from the Clinical Journal of Sports Medicine in 2004. The main reason that athletes don't report symptoms is they didn't think the concussion was serious enough. So it's hard to fake a broken leg. It's easier to fake a concussion and hide those symptoms. So athletes do underreport symptoms. So just in summary, with the youth and high school sports, overall the concussion risk is low. So we looked at youth football is about 3%, high school football about 10% per season. Football and girls soccer have the highest risk. Females are greater than males for the same sport. Game risk is a lot higher than practice risk. Player-to-player contact poses the highest risk, and then we know that athletes underreport symptoms as well. So those are things that we know. So moving on to things that are a little bit less clear. So subconcussive impacts. So that's something, so you look at football, so every football game there are tons of times where athletes hit helmets, but they don't get a concussion. So the question is, are these subconcussive impacts, are they anything to worry about? So overall the data is very limited, especially in youth and high school sports. There's some data on professional athletes. They've done some studies on professional soccer players, looking at problems with their brains later in life. There's really no evidence of a short-term effect, and we don't have a ton of data on long-term effects either. So this study was from the Journal of Neurotrauma in 2011, and it looked at impacts per season. And this was with high school football. And they found that the linemen have the highest number of these small impacts. So they put sensors on the helmets and followed them throughout the season. Linemen followed by tight ends, linebackers and running backs, quarterbacks, and then wide receivers and defensive backs. And they also found that there was no association between the number of impacts and the concussion and risk of concussion. This is a really interesting study. So this was from back in 2012. It was done in Minnesota. So what they looked at, so they took two groups that they looked back at from 1946 to 1956. So they looked at football players, and they looked at those football players' classmates who didn't play football. And they looked at a certain period of time around 2012. It was probably done a little bit before then, but they looked at rates of dementia, Parkinson's, and ALS. So those are neurocognitive diseases that are usually seen later in life. And they found that there was no difference between any of those between the football players and their classmates who didn't play football. Other things to consider: there's no correlation between winning percentage and concussion. So if your child or grandchild's on a bad team, that doesn't necessarily mean that they're going to have a higher risk of concussion. This study in the Journal of Neurosurgery looked at soccer heading, and they concluded that reduced neuropsychological performance was found after minor head impacts in soccer, even in allegedly asymptomatic players. However, the long-term cognitive consequences are uncertain. So again, we don't really know. I think the vote's still allowed on heading and soccer. What about athletes with recurrent concussions? So there's a prolonged recovery and return to play, and those athletes who have had a concussion or have had more than one concussion, they have longer symptom resolution times and thus the longer return to play, prolonged cognitive effects, and they are also at increased risk for a subsequent concussion. And I like to tell patients that having a concussion puts you at risk for another concussion, and having a second concussion puts you at further risk, and so your threshold goes down with every subsequent concussion. Every athlete's different, every concussion's different. There may be some genetic factors in there too that make an athlete susceptible to a concussion. So in general, with repeat or recurrent concussions, we really don't know the long-term risks, especially with youth and high school sports. So looking at prevention, so how can we prevent these concussions? And there's been a lot of work with this. So some people ask, well, why can't we just make the helmets a lot better? The two studies that I found that looked at helmet types, one's from last year from the Journal of Neurosurgery. So they followed 8 Division I college teams. They looked at 2 different helmets, so the Riddell VSR4 and the Riddell Revolution. They found that one of those, there was a difference in concussion. I don't remember which one, but it's kind of like, well, if you're not using that helmet, then really who cares? But that's the only study that I've ever heard of that actually shows a difference between concussion and helmet type. That same year, the American Journal of Sports Medicine put out a study looking at high school football, and they found no difference between any helmets in football. Mouth guards don't prevent against concussion. They do prevent against dental trauma, so they're good overall, but they don't prevent against concussion. And then soccer headgear with heading the ball doesn't prevent against concussion either. So this is what I mentioned previously, this symptom-free waiting period. Is there evidence that athletes, after they become asymptomatic, should they wait a little bit longer? Should they wait 3 days? Should they wait 7 days? Does that matter at all? And there are two sides of things. So I like to look at the pros and cons, and then I'll kind of give you my recommendation. So looking at the pros with this, we know that repeat concussion risk increases within 7 to 10 days. So after an athlete sustains a concussion, within 7 to 10 days of that concussion, they're at a lot higher risk of getting another concussion. Some people will just say, well, the benefits outweigh the risks, so let's just, it's not doing them any harm to rest them for another week, so let's just put them out for another week and give them that extra rest. So the cons to this, so there's really no specific evidence that a symptom-free waiting period does anything as long as you're out of that 7 to 10 day window. The risk of doing the symptom-free waiting period, so let's say an athlete gets concussed, they wait about 14 days until everything's normalized, and then you say, okay, well, let's wait another 7 days. So that's 21 days, that's 3 weeks where they haven't been doing anything. And then you start them back in their return to play, and they may injure their knee or ankle because they're deconditioned. They haven't been doing anything for 3 weeks. We know that athletes, when they're out of sport, they have increased anxiety and depression. So that's another thing to consider. And then if I were an athlete in high school and a big game was coming up, and I knew that my athletic trainer or someone was going to sit me out an extra 7 days, I would probably underreport my symptoms even more so. So there's that thought as well. So as far as how I deal with things, and this is just me, the younger the athlete, I'm more conservative with them, so I tend to give them a little bit more rest and prolong their return to play progression, so their brains aren't as developed and they take a little bit longer anyways. If an athlete's had a prior concussion, I tend to be more conservative because their threshold for getting another concussion is a little bit lower. And then I really advocate this. So instead of symptom-free waiting period, what I would do is I would just extend that 5-step process where the athlete starts with aerobic activity, and then they go on to sport-specific drills, and then they go on to non-contact practice. Why not just do 2 days of the aerobic activity and 2 days of the sport-specific drills, and so you're extending that from 5 days to 7 days or 8 days. They don't get deconditioned; they're still hanging out with their teammates, and so that's what I tend to advocate instead of a specific symptom-free waiting period. I'll skip that. So this is kind of wrapping it up. Where do we stand right now? So there's unknown long-term risk of repetitive subconcussive impacts in football, unknown long-term effects of soccer heading, no known or proven long-term neurologic effects of playing youth sports and high school sports. There's an increased risk of repeat concussion within 7 to 10 days of prior concussion, and we talked about this symptom-free waiting period. And we know at this time that there's no helmet type, mouth guard, or soccer headgear that reduces the risk of concussion. Questions that we still have to sort out. So how much is too much? How many concussions are too much? I think a lot of that depends on the athlete. Again, we treat every athlete's unique, every concussion's unique. Is there definitive evidence of a long-term risk? Maybe with some of the professional athletes, but that's kind of up in the air as well. So this came out from the American Journal of Sports Medicine in 2015. And they said the study of concussions in the NFL has been limited by lack of recent empirical data, reliance on self-reported concussion history, and ascertainment bias of brains donated for autopsy studies. The scientific community, as well as the public, should be cautious in interpreting the current literature surrounding concussion. So some future directions. Advanced imaging techniques, things like MRI, are evolving to potentially be helpful with diagnosing concussion. There are blood tests or serum markers that could potentially be helpful in that they show an elevated level of a certain protein. Virtual reality is being used both with diagnosis and management of concussion. As far as specific for management and getting these athletes back to returning to play faster, hyperbaric oxygen is one thing that's being looked at. And then I was involved in a study that's still going on at East Carolina University looking at omega-3 fatty acids in athletes returning to play faster. So, final slide to wrap this up. So concussion injury is a gray area, and I always say that. So it's not black or white. Sometimes I know a concussion when I definitely see it. Sometimes I'm pretty sure, no, that's not a concussion. But most of the time, it's gray area, and it's difficult to diagnose, and sometimes it's difficult to manage as well. So every athlete and every concussion is unique. I would say overall, if you're considering letting your kids play sports or thinking about playing sports yourself, I'd say the benefits of athletics overall, it outweighs the risk. It has a lot of health benefits to be active and involved in sports. I can't say this definitively, but there's unlikely major long-term risks if somebody just had a concussion or two. And then the majority of data showing possible long-term effects from concussion and or subconcussive impacts was done in professional athletes. So appreciate your time. If you guys have any questions, my email's on there as well. If you guys have any specific questions that you think about later, you can email me.